For today's meeting, we'll go ahead and get started. Today's agenda will start with VEST update, followed by vaccination unit update, DCLS update, modeling update, other PH ops, and then questions and updates from local health districts, which will be utilized in the chat box. To start things off, we'll go ahead with the VEST update with Bob Moskoff. Bob, if you're on the call, can you please take it?
Yeah, thank you very much, James. Can you hear me?
Absolutely. Yes, sir. Go ahead.
Oh, thank you. Update on what the VEST is doing. The president announced his intent, his vision for supporting the states in the vaccination effort and the overall COVID effort this week. One of the items that they mentioned was establishing sites, federally run sites across the state for what we're calling now centers, not mass vaccination, community vaccination centers. And so they would be run, and he's planning on 2 or 3 per region. So our region is Region 3 from Pennsylvania down to Virginia and West Virginia. So we're looking at the possible siting of totally run federal centers for vaccination. The other possibility that they're looking at is federally supported centers. So like what we're doing, planning state support to local centers, they're looking at falling in with us and providing that. They're also providing that. So we'll be working with our federal partners. They'll have an incident management assistance team at the State Emergency Operations Center commencing on Monday. We'll have folks over there working with them and the Department of Emergency Management. I also commented early at an earlier meeting that the VEST, the Virginia Emergency Support Team, has activated an incident management team for the purpose of large vaccination sites and large vaccination support. We had hoped that the Guard would be available to assist in this effort as early as early February. That's going to slide at least a month or about a month because they've been extended in DC for support to the district for a week or so. So once they get back, we're going to look at mobilizing between 200 and 250 to support local efforts. The regional coordinators from VDH and their counterparts from VDEM and this incident management team have done analysis of well over 40 sites across the Commonwealth. And we're focusing on those up and running and doing a great job right now with pretty much large throughput so that we can provide support. The analysis of what they're doing as far as staffing plans. And as I said, the local jurisdictions and health districts are doing a good job. But we want to provide some continuity and consistency across that. So that's the direction that the Virginia Emergency Support Team is taking. We also are in an influx of funding to support our vaccination efforts. And we don't know exactly how that distribution will get probably a cooperative agreement. It'll probably come out of FEMA. So our folks working with this IMAT that I mentioned is coming on Monday, will be working closely with them. I won't go into the data information because that'll be covered on the vaccine side, but I'll turn over to Susie with some information on resources. Suze?
Thank you, Bob. I saw in the SITREP this past week that there were several people that indicated they had some shortage of ancillary supplies and PPE. So I just wanted to remind everybody of sources where they can get both. First, the ancillary supplies can be ordered from Central Pharmacy through WebVision. Some of those supplies include Band-Aids, alcohol wipes, cotton balls, sharps containers, EpiPens. So just place your order there and the pharmacy will send it out to you. Unified Command is still providing PPE to districts. You need to complete the form, the online form, and the link is there. Orders are due by 5 p.m. on Tuesday for delivery the following week. We are still taking special requests and urgent orders. So if you have a large event that you've planned, so it doesn't account for that in the PPE survey, all you need to do is send me an email letting me know how many of each item you want and by when. If you can get me the information by Tuesday, I can get it added to your order that's being delivered the following week. We also have this process in place if you have an urgent order. You ran out of something, you didn't get a delivery for whatever reason, you need something quickly, email me, let me know what you need, and I can get it out to you as soon as possible. The other thing I wanted to mention that doesn't have to do with supplies. Oh, let me go back. I thought Bob was going to mention it. On a couple of the calls, we've mentioned that the governor's office had a project to get PPE out to districts, daycares, free clinics. Some of that PPE has gone out to the districts already, all except one item, and that is the gloves. And those are being shipped today. So each district will be getting 144,000 gloves in sizes to use for vaccination. So please make sure you accept those orders when they get delivered. And then the last thing I want to mention is the latest update to the Vaccinator training plan. Bob Hicks had sent out information on the MOA for EMS providers to assist with vaccination. And that required a few language changes in the training plan. So those were made and updated in the plan. It's nothing significant. It was just language changes, but I just wanted to make you aware of that. And that is it for my update, and I will answer questions in the chat.
Thank you, Susie.
Yes, Susie, I just want to point out one other thing, and that the 144K going to each of the districts does not change their weekly allocation that will continue to come.
Thank you, Bob. Next up, we'll have the vaccination update with Marshall Vogt. Marshall, if you're on the call, please take it.
Good morning. If we could go to the next slide, we'll provide an agenda of what we're going to be covering today. We'll talk a little bit about updates that have come out from the Vaccinate Virginia campaign. We'll go into the pre-registration data collected from the VDH Jebit tool, as well as updates to local health district websites and the long-term plan for collecting pre-registration registration data. We'll talk a little bit about VIS and VANS. There's some updates there, as well as for PrepMod, and then we'll finish up with some pharmacy partnership updates and DBHDS updates. So if we go to the next slide, as you're aware, there was a press conference that was held this week by Governor Northam. Major updates provided by that press conference were that all of Virginia is now in phase 1B. That doesn't mean that we have stopped working on any remaining phase 1A eligible vaccine recipients and getting them connected to vaccine, but we have moved into phase 1B. We are closely monitoring all doses of vaccine that have been received and distributed versus doses that are administered. There's a new dashboard on the public-facing VDH website. You see it is linked there, and that does a little bit of a better job of breaking down where doses have been distributed and where doses have been administered, and first versus second dose allocations. There's really been an ask that if hospitals were or other facilities were sitting on doses that were intended to be second doses and they have not been administered, to get those out as first doses, and we will work to ensure that second doses for everybody are available as we do our ordering. Speaking of our allocations and our plans for 1B, the ask is that roughly 50% of the supply that comes to local health districts, and all vaccine now is being sent to local health districts, should be used for people 65 and older, with the other 50% earmarked for frontline essential workers, people with high-risk medical conditions as identified by the CDC, and people in correctional facilities, homeless shelters, and migrant labor camps. If we go to the next slide, we'll talk a little bit about that data for kind of capturing who is eligible for a vaccine and getting them connected to a vaccine. As I mentioned last week and on the Wednesday local health district technical assistance planning calls last week and this week, you remember VDH deployed a tool on the main website, the main VDH website called Jebit, or based on the Jebit platform. A lot of people called this the vaccine eligibility quiz. It collected data from constituents who used the tool, and it helped determine what their priority group was based on their answers. But it also did collect contact information from those users. We had data that was collected for over 400,000 registrants, and it was sitting in this database that was centrally housed. And we realized that we really needed to get that data out to local health districts because right now it is you all that are able to connect with those individuals and get them connected to vaccine opportunities. So the first thing we did is transform the Jebit tool so that it informs users of their vaccine priority group and then directs them to local health districts and their websites for further information, including opportunities for pre-registration. And then we asked all of you to transform your local health district websites to include information on your current vaccination opportunities and provide a method for these individuals to indicate their interest in receiving vaccine, either through kind of a survey or the ability to call a number and get some more information. So if we go to the next slide, that brings into question, what do we do with all of that data that was collected by that centralized Jebit tool on the VDH website? And what we did is we analyzed and parsed out that information by health district, and we sent that out to health districts so that you all are able to, use that information and couple it with any information that you might have been collecting and add it into the information that you're going to continue to collect. And the purpose of that is so that you can reach out to these individuals that are eligible for vaccine when you do have vaccine available and you're doing clinics and get them connected to vaccine. What we want to do is develop a standardized tool that will be used across all local health districts and can be placed on their website. And that will allow for standardized data collection, but local health district level access for that data. And we're in the process of talking with the Chief Information Officer for the Commonwealth of Virginia and others to help develop that tool and really roll something out that is going to be kind of standardized across the board for everybody, but meets everybody's needs. Of course, the long-term goal is to use the PrepMod system for vaccine registration. As we move toward these more open point of dispensing sites, people will hopefully be able to go type in their zip code, find a site near them, and go receive vaccine. So the transformation of the Jebit tool, getting this data out to you, is really for these phase 1B individuals. We do want to standardize those processes, and that's what we're working to do now. But long term, we're hopeful that PrepMod will be kind of that ultimate answer for all of those questions. If we go to the next slide, just want to remind everybody about this. If you are currently using VAMs for your vaccine clinics and you're having any issues with VAMs in terms of getting that data in there, this is a backup for entering that data. Remember, VAMs is preferred right now because it acts as a medical record. This does not. So if you do enter doses administered data into this, please remember that you do need to retain those forms as a medical record. But regardless, please make sure that if your clinics in VAMs are not operating smoothly, the doses aren't being entered as they're being administered, please be sure that those doses administered get entered as soon as possible. And if you need help with data entry training or support, please contact Bill Edmonds and he can put you in touch with some resources. We've also heard there's a system called VRIP, which is really how we register people for this and other immunization systems. There have been anecdotal reports that have come to us that some people are saying that individuals need to go in and create a VRIP account so that they can pre-register for vaccine or register for a vaccine appointment. That is not the case. We do not use the VRIP system at an individual level for those sorts of things. So if anybody has been referring people to that, please don't, because that does create confusion for the folks that are trying to enroll providers and use that system for its intended purpose. If we go to the next slide, I do see some questions in the chat about VAMs. We are still using that, but of course we are going to be slowly transitioning over to PrepMod, and I have a little bit more to say about that in some subsequent slides. But as you're using VAMs still, please be sure that you're using the latest templates. Those continue to be posted on our internal website. And send those templates to Charles Jones. Again, my thanks to Charles for his quick turnaround in getting your clinics and employers and organizations uploaded into VAMS. Please remember to use the right VTRAX PIN and VIS.org ID. They have got to be included so that that doses administered data from those clinics comes over to VIS properly. Now, the folks in VAMS that are doing the programming have changed a little bit how treatment station hours work in terms of their functionality. I did send out an email to folks about that. It's not ideal. I've heard from many of you, and so if you have issues with treatment station hours and how you're configuring them, please reach out to me and I can connect you to the folks down at CDC. You can use the clinic station absences feature that is in there to get around some of the changes that have been made that might really affect your workflows. Please reach out to me if you have issues, and we can try to get you connected to CDC and get you all help. We also received notice from CDC that there are some individuals in some clinics across the state that were checked in to the clinic workflow, but they never had a vaccine administration that was documented. So it could be that they were checked in and maybe left the clinic. It could be they were checked in and there were issues with their VAMS account, and somehow the vaccine was administered, but it wasn't documented in the system. What we have done is found clinics where at least one instance of this occurred, and an email was sent out by Charles on Tuesday of this week to any clinic administrators, those initial people that set up the clinic, where there were instances of this occurring. And what we've asked for you to do is follow the instructions in that email. Basically, you need to just find those recipients that are checked in but haven't received that vaccine according to the system. They're in this kind of limbo status, and verify their vaccination. And if they've gotten the vaccine, just make sure that's logged. If they haven't gotten the vaccine, cancel out that appointment so they're no longer in that limbo status. Again, more information is in the email, and if you are affected, any clinics in your district are affected, you have gotten emails about that already. If we move to the next slide, that's just an intro slide for PrepMod updates, and so we can keep going to the next slide after that in the interest of time. This slide shows where we are in terms of onboarding districts onto PrepMod. I apologize that the font's probably a little small for you all to see, but you can see that our pilot and Wave 1 groups are already on board. This was created a couple days ago, so we're really into Wave 2 and 3 now in terms of getting training out to people and starting to really use PrepMod for planning and executing clinics. So again, this represents the shift from using VAMS to using PrepMod for vaccine clinics. My thanks to the PrepMod team, Sue and Bill and Nitin particularly, and some other trainers as well. You guys have been doing a great job in getting districts trained and onboarded into PrepMod. As we go to the next slide, this has some important kind of dates and times for you to pay attention to in terms of go live dates for both Wave 2 and Wave 3. Again, our goal is to get everybody using PrepMod by early February, and then office hours and trainings. And of course, we know some of you are still using VAMS to finish people up in the system. If you've done first dose clinics in VAMS and people are coming back for second doses, it's best to finish them out in the system. As you're planning clinics for people that are just beginning to receive vaccine and you're going live with PrepMod, please use PrepMod for those clinics. If we move on to the next slide, quick update on ancillary supplies, and I believe Susie had touched on some of this, but for some of those other ancillary supplies that are available through pharmacy services, we have heard that there's been some shortages of Band-Aids and cotton balls. These items are available via Central Pharmacy. Orders can be placed in WebVision, and products are in a catalog in WebVision, and they all start with COVID, so it's easy for you to locate them. There are details on the internet about how to do this ordering, but if you have questions, please contact Tim Tompkins, or Susie Silverstein. And our thanks to those folks for ensuring that there is availability of those items. We'll move now to some long-term care facility updates that Stephanie Wewell asked me to pass along. She is off today, but my thanks to her and to Mike Magner, Monica Bazar, and the entire team for working tirelessly to get folks vaccinated that are in this kind of realm. You can see here on the diagram that across all long-term care facilities, the federal partnership with CVS and Walgreens is going to target just over 1,300 SNFs and ALFs and a few other facilities. But there are still some facilities that are not covered by this program, and those represent some skilled nursing and assisted living facilities that are outside of the federal pharmacy partnership program, independent living facilities, senior housing facilities, and then DBHDS group homes. So there is kind of on the right side of that chart there, an area where there really is the need for local health departments to be partnering with these facilities that were not covered by the federal pharmacy partnership program. And if you go to the next slide, you can see kind of an update as to where we stand. So there are total doses that have been administered by the CVS and Walgreens partnership, including the total first dose events. And then you can see that there were some unneeded doses that were allocated, and they're being used to help with central coordination to vaccinate remaining facilities. So those facilities that are kind of on the right side of that chart that I showed you in the previous slide. And the idea is that we're trying to use pharmacies that might be able to help go in and provide doses to some of these facilities. So you can see there are 12 pharmacies are receiving 3,400 doses with the hope that they can target some of those independent living facilities. And then 4 pharmacies are receiving about 1,600 doses to vaccinate behavioral health group homes that are administered by DBHDS. The vaccination unit is working to provide details back to respective health districts to kind of close the loop and let you know what is going on with this. But the idea is that for these individuals that aren't covered by that federal program, we're trying to identify who's not covered and find ways to help get them connected to vaccine without putting too much onus on local health districts. If we go to the final slide in my updates, just some additional updates for the federal retail partnership. Again, that's a separate federal allocation, and that's going to start with CVS pharmacies, hopefully in mid-February. And remember, that's a federal partnership that's going to try to provide vaccine to large numbers of people in the communities. It's separate from that long-term care facility partnership. And of course, we're also working to kind of replicate that at a state level. We have 458 pharmacies that have signed an MOA, completed CDC enrollment, and they're ready once they get vaccine and can really stand up operations to partner with local health districts and help vaccinate folks in the community. The Virginia Pharmacists Association has also worked to create a relief pharmacist list to help pharmacies that may need some additional staffing resources. And then, of course, we're encouraging our pharmacists to sign up for the Medical Reserve Corps as well. If there are questions about these sorts of things, please contact Christy Fletcher. Her email is on the screen there. Or, as always, you can reach out to Stephanie Lewill. Finally, just the last slide. As always, thank you for all of your hard work. I know we're all kind of running on empty and trying to push through fatigue, but thank you for everything that you're doing, and may we all be as happy as Anthony Fauci as he's been interviewed these past couple weeks by the press. With that, I'll turn it back to the host, James, and I'll try to answer any questions that have come up in the chat. Have a great weekend, everyone.
Thank you, Marshall. Next up, we'll have the DCLS update with Marilyn, Freeman, and Colleen, Courtney. Can one of you please take the call?
Yes, this is Marilyn. Can you hear me?
We can. Please go ahead.
Awesome. Can I go to the next slide, please? Perfect. So DCLS's week at a glance, we did perform 4,121 PCR tests, no serology tests, and shipped out 2,090 kits. This is just a reminder that we do still have additional capacity both at DCLS and within the One Lab network. Just contact our representatives here or through VDH and we can get those scheduled. I do want to highlight that DCLS preliminarily identified SARS-B117 last Friday, and we were able to confirm that preliminary identification on Monday of this week. It was reported promptly to the health department as well as the governor's office and reported in the press conference as well, a press release as well. We have been continuing to receive additional samples for sequencing from commercial laboratories, academic facilities, as well as hospitals within the Commonwealth to help us screen effectively for the variants of interest. We continue to perform daily same-day priority testing for the National Guard, which began on January 10th. Since that time, we've tested 2,491 samples. I do want to take the opportunity to also thank Fairfax County Health Department last weekend, who assisted us through our One Lab network in testing some of the National Guardsmen as well. Next slide. So last week, Thursday, Friday, and Saturday, we were very close to the sample schedule versus the samples received, but I do want to point out that we do still, based on this graph, have additional capacity that can be used throughout the week and also on most Sundays. Next slide. That is actually all for me, and I'm happy to answer any questions in the chat.
Thank you for that update. Next up, we'll have the modeling update with Justin Crow. Justin, will you please take the call?
Yes, thank you, James. Next slide, please. Normal background slide. The model does continue to get updated based on more and better data, including new data on vaccine deployment and the new variants that we're seeing pop up. Next slide, please. A look at the national trajectory. A lot of this has changed recently, and I think is different than many of us may have expected following the holidays. Currently, there's only one state in a surge trajectory, and that is the state of New York. Most states are in declining or plateauing trajectories. Virginia is in a slow growth trajectory, and this is the change from last week when we still saw a lot of coastal and southern states experiencing surges in growth. Next slide, please. A little closer to home, we're seeing a similar kind of pattern. We're seeing declining cases among most of our neighbors. The exception is North Carolina, which now has the highest case rates of all of our neighbors. There is a caveat to that. Kentucky and Tennessee still have high test positivity rates, so they may be missing some cases, but this decline, however, has been is good news for us. Virginia also had a sharp decline in cases last week. We reported about 72 new confirmed cases per day per 100,000 residents. It's dropped now to about 54, so a 26% decline in cases in Virginia. Next slide, please. Across the Commonwealth, we're seeing a similar pattern where cases were initially very high in the southwest area and a little bit in the northwest Virginia area. We've seen sharp declines in cases in those areas, and now some of those counties are among the lowest, have the lowest case rates in the state. The exceptions, of course, being Lee County and Southwest Virginia and a couple counties in the northwest area. Rather, we've seen high case rates move more inland to Southside Virginia, heading slowly eastward. We've been watching really closely what's been happening really in our large metro areas, which have the highest population. We've seen some inroads and some short-term surges, but none of the same sustained high rates that we saw in Southwest Virginia and other areas of the state. So we're continuing to keep an eye on that. I do want to point out the case rates are still high throughout most of the state. The scale on this map was increased from where the highest, brightest yellow there was 30 cases per 100,000. Now it's 80. So the light green is, 60. So when I say relative, it's comparatively cases are still high in most places throughout Virginia. But we're not seeing those sustained extremely high rates in our metro areas that would drive Virginia's case rates extremely high as well. Next slide, please. We're seeing the same pattern with our trajectories. This is showing you the direction of change, but not necessarily the level of change. But we're seeing most of our growth and surge trajectories in Southside Virginia and a little bit in the Northwest areas. However, 20 local health districts have experienced declines, are in a declining trajectory, and 2 are at plateau. Only 13 are in growth scenarios. Next slide, please. We're still continuing to report transmission rate by confirmation data. As you might expect from the previous data, we have seen statewide declines in transmission rates, as well as declines in every region of Virginia. Every region of Virginia has a transmission rate below 1, so matching what we're seeing in the data. Next slide, please. And our symptom onset to diagnosis continues to remain lower, continues to kind of tick down. It's at 4.1 in January, matching what we saw in December, but lower than what we saw early in the fall. Next slide, please. And we continue to track the risks. I believe I noted this last week, but there was a CDC modeling study looking at the UK B117, or the variant B117 variant first identified in the UK, that stated that that variant could become the dominant variant by March. Of course, that would be over half of the cases identified responsible for would B117 would be responsible for, and that would continue to grow through the summer. And the vaccine rollout is beginning to have an effect on cases, but that will increase and have the largest effect in late summer. Next slide, please. The UVA team is looking at some Facebook administered surveys looking at vaccine acceptance. They are able to create specific estimates of vaccine estimates for several counties in Virginia, and then they also look at the rest of Virginia, which are mainly our rural or smaller population counties where they don't have as many responses. So for most of the state, that sort of a moderate green there shows that about 70% of the people in those areas would definitely or probably choose to receive a COVID vaccine if offered it today. And of course, you can see in Northern Virginia, the Richmond area around Williamsburg, Charlottesville, and Roanoke, some areas where we see higher acceptance rates. Next slide, please. I think I've discussed these scenarios previously, so I'm not going to go into too much detail. The UVA team does model a best of the past. It looks at the lowest transmission rate by county, and also a fatigue control scenario, which looks at the highest level of transmission by county and projects those forward. Next slide, please. They continue with the novel variant scenario. I do want to note that they updated last week. In this scenario, they increased transmission by 50%. I'm sorry, by 40%. Based on the studies that they'd seen this week, they upped that to 50%, just to get a little bit more idea of what what a worst case scenario with a novel variant might be. They also changed the verbiage here, not the model. They increased transmissibility over the course of 4 months. Previously, they had listed 2 months, but that is when they expect the new variant to become dominant, but it would continue to push out the other variants. So they've extended, just to define this a little better, through 4 months, they would expect transmissibility to increase in the new variant scenario. Next slide, please. And they've also simplified the way they're handling vaccines. If you recall from previous weeks, they had an optimistic and a pessimistic vaccine scenario. Since the logistics around this are stabilizing to a degree, and they've simplified how they're looking at that. And they've also changed the way they're viewing vaccine hesitancy. Since demand far outpaces supply, they're not really considering vaccine hesitancy for the short term. However, it may have an effect on, of course, uptake in the number of vaccines administered in the long term. But as long as demand is outpacing supply, that won't affect how they model the vaccine. So next slide. So this is just a summary of what they're expecting rates in Virginia for or about 100,000 per day going forward is how they are modeling the vaccine. They continue to keep a close eye on how that works and if that situation changes. But right now they're expecting sort of a steady rate of vaccinations. Next slide, please. So put together, we have the adaptive fit, which is basically the current course continued forward with that vaccine model included. The fatigue control, which is a worst case scenario, projecting kind of some of our worst increases from the fall forward. Our best case scenario, which when we managed to lower transmission rates, projecting that forward, and then the new variant scenario. Next slide, please. So looking at those scenarios, this is the current course adaptive. We expect a peak of about 45,000 cases in early March. Much lower than previous cases. The declines that we saw are affecting projections. So we're seeing some volatility here that is affecting in the data, which is creating some volatility in the results. Next slide, please. The fatigue control scenario is a little different. We see a peak that's very similar to what we saw with the adaptive scenario. It's 46,000 again in early March. However, you can see a much wider curve there. So under the fatigue control, the pandemic lasts a little bit longer, I guess is how we would put it. So into May and even into June and July, you see high case rates under the fatigue control scenario. So the peak isn't as high, but it is a broader curve there. Next slide, please. Under the new variant scenario, you see the peak is about 57,000 cases, so much higher with the new variant scenario. However, not as wide as the fatigue control scenario. So we do see that higher peak in early March, a little bit later in March, but we do see a quick decline with the new variant as well. Next slide, please. And this is just a summation of what I just showed you. I do want to point out in the graph on the right, the new variant line is the red line, whereas the fatigue control line is the yellow line, and the blue lines are the current course and the best past control scenarios. So you can see with the fatigue control line, you know, the pandemic kind of lasts a little bit longer, even than the new variant line there. So what this kind of tells us is that mitigation strategies, keeping transmission low, does have a big impact on the course and really the duration of the pandemic. Next slide, please. With the adaptive, the current course that we're looking at right now, we don't expect hospital capacity to be breached at the 80% level or at the certainly not the surge capacity level of 120% of beds, which is our rule of thumb for that. Next slide, please. And just where you can get updated and more detailed information. And that's all I have for today. Thank you. I'll check the chat for questions.
Thank you, Justin. Next up is the other PH ops, which includes health information, investigation, surveillance, containment, and informatics and information systems. With that is Carrie Holsinger. Carrie, if you could please take the call.
Yeah, hey James, can you hear me?
I can, please go ahead.
All right, well, good afternoon, everyone. This is Carrie Holsinger. Next slide. All right, so the health information team updated the general FAQs and the vaccine FAQs this week. As a reminder, the general ones are updated every 2 weeks. The updates involved several sections listed here: businesses and workplaces, K through 12 school settings, the travel section to reflect the order that went into effect on January 26, requiring proof of negative test results or recovery for individuals entering the U.S., as well as restrictions of entry of non-U.S. citizens. New questions were also added on receiving text messages from BDH after testing positive and on exposure notifications from COVIDwise and COVIDwise Express. The vaccine FAQs are updated weekly, and these will now be posted on Wednesdays instead of Tuesdays. This week's updates includes getting vaccinated in a different locality, vaccine for federal government workers, vaccine-related scams, use of medications to reduce side effects, vaccines in those with convalescent plasma or monoclonal antibody, antibody testing after vaccination, TB testing and COVID-19 vaccine, return of the Pfizer BioNTech vaccine shipping container, and co-administration of COVID-19 vaccine with other vaccines. Other updates include this week information on severe allergic reactions and allocation of vaccine in phase 1B. Next slide. So as of yesterday, 2 cases of B117 have been identified in Virginia. So the Health Information Team worked to update materials reflecting this confirmation, including developing a clinician letter and reviewing a press release, which DCLS mentioned. The press release, of course, both of those went out actually on Monday. The Health Information Team also updated the talking points for new variants that are posted in the Disease Control Manual. It is worth mentioning that the talking points about the clinical severity associated with B117 infections were revised. Preliminary reports suggested that there is increased severity with this variant, and scientists are investigating this further. If you recall, previously we had said that there was no evidence that these variant infections were more severe, so we have updated that information. Several travel restrictions took effect this week, including a CDC order requiring proof of a negative COVID-19 test within 3 days of entry to the United States, or proof of recovery for individuals over the age of 2 entering the U.S. by plane. The president also issued a proclamation this week that limits entry of non-citizens from several regions where variants of concern are circulating. The entry ban for South Africa takes effect on Saturday, January 30th, and the bans for the other areas took effect on Tuesday, January 26th. The VDH travel website was updated on Wednesday to reflect these changes. Lastly, we just want to note that the team continues to streamline their web pages to try to enhance the user's experience by describing what topics are covered on a particular page and improving the overall readability of content. Most of these will be completed by Monday, February 1st. Also, for the next 1 to 2 weeks, the team is going to be working with the testing team to reorganize and streamline the testing resources and materials for healthcare providers. And then finally, just an update that the Get the Facts box, which used to be a part of the VDH homepage, has been retired. Next slide. So moving on to updates from our healthcare associated team. The team continues to communicate with CDC about direct outreach to Virginia nursing homes from federal partners. We are notifying health districts when we are made aware of outreach to specific nursing homes. CMS is calling nursing homes that reported 10 or more new resident cases to NHSN during the previous week. They're asking a standardized set of questions, including, is the facility working with a state or local partner on their current outbreak? If the facility answers no to that question, CDC will email the HAI-AR team to make them aware and verify that we are providing the support. CMS will also offer facilities a virtual strike team visit in which they are using to understand how the outbreak will unfold, identifying critical actions that will help the facility contain the current outbreak and prevent transmission in the future, and then lastly, identifying lessons learned that could benefit other facilities and inform state and federal support activities. When those virtual visits with CMS get scheduled, CDC will inform our team, who will then forward that information to the local health department to join if you're available. In a separate outreach activity, HHS is also calling nursing homes to report shortages of testing supplies, staffing, or PPE to understand what state and local support can be provided to these facilities. Next slide. So this slide illustrates the number of new resident cases in the red line and the number of resident deaths, the orange line, reported each week from Virginia nursing homes. As you can see, the number of new residents cases has been increasing, with the week ending January 10th having the highest weekly count reported to date with 950 cases. That is almost 200 more cases than the previous week ending January 3rd. The number of new resident deaths has also been steadily increasing, with the week ending January 10th having the highest weekly count reported to date with 156 deaths. Next slide. Here you see Virginia State Profile Report, which is sent by HHS. This includes data that's more recent than what I just presented on the previous slide, and some things that we want to share. Here, 33% of Virginia nursing homes reported at least one new resident COVID-19 case during the reporting week ending January 17th. This was 6% less than what was reported from Virginia nursing homes the previous week. So given this data is more recent than the prior slide, we may be beginning to see a decrease. However, even at this percentage, Virginia is still 7% higher than the percentage of nursing homes across the United States. Further, 54% of Virginia nursing homes reported at least one new staff case. This was 13% less than what was reported in the previous week, but again, still 11% higher than the national average. And lastly, 25% of Virginia nursing homes reported at least one new resident death. This was 2% more than what was reported the previous week and 10% higher than the national average. Next slide. So moving on to our surveillance section, there have been over 2,200 confirmed outbreaks created in VOS. 38% are in long-term care facilities, while 22% are in businesses and workplaces, and 13% in education settings. Next slide. This slide shows the number of outbreaks by week reported to the Office of Epidemiology. For the week of January 17th through January 23rd, a total of 78 outbreaks were reported in VOS last week with a confirmed etiologic agent of SARS-CoV-2. Next slide. Between December 1st and January 25th, 94 outbreaks, both suspected and confirmed, were reported to VDH in K-12 school settings. 34 of these outbreak investigations, or over 36% of all K-12 outbreak investigations reported in December and January, occurred in school sports teams. Before the month of December, only 2 outbreaks in K-12 school sports were reported in VOS since the beginning of the pandemic response. We will continue to update you on K-12 school sports outbreak data, as we know many schools are launching both fall and winter sports seasons now. So just a reminder to please make sure that all outbreaks occurring in school-associated sports teams are entered into VOS as the appropriate educational facility, either K-12 or college or university. The sports club category should be used for non-school sports groups, such as travel teams not affiliated with the schools or adult sports leagues. If you have any questions about this, please contact the VOS team using the email on the screen. Next slide. So regarding reinfection surveillance, Central Office has finished uncounting the second investigations for potential reinfections. This is in keeping with what other states are doing. Central Office will provide the number of cases uncounted per district for awareness. This also serves as a reminder to please investigate a positive molecular test 90 or more days after an initial positive. Enter an investigation in VEDS and mark it as not a case. We're particularly interested in indications of severity, onset date, and symptoms. Central Office has begun to analyze this information, and we do plan to present our findings soon. And as we hear more information on variants identified in Virginia and in neighboring states, it's going to become even more important to be able to identify these situations of potential reinfection. We're working with Dcls right now to develop a pathway for paired specimens that exist at one lab facilities to be forwarded to Dcls for sequencing. Next slide. So moving on to our containment update, an MOU previously developed to provide funding to local health districts for COVID-19 district epidemiologist and care resource coordinator positions is under modification to add additional funds to support the hiring of data entry positions. Each health district will be receiving just over $498,000 that can be used to cover expenditures from July 2020 to November 2022. Health districts can utilize these funds to support the funding of a COVID-19 district epidemiologist, care resource coordinator, and/or data entry position. Health districts will have the flexibility to utilize these funds to hire those positions as they see fit. This funding memo is expected to be signed by CHS and Office of Epi leadership shortly and distributed to health districts for their records. We also want to remind health districts that have a need to hire additional containment positions, such as case investigators or contact tracers. Please reach out to John Ringer to request more resumes to screen. And if a health district has individuals that they want to directly offer positions to outside of the normal recruitment process involving screening and interviewing, they can utilize a district referral ticket and submit that to John Ringer to bypass this process. While this will aid in bypassing the application, screening, and interview process for the individual, they will still need to be processed by HR and the contracting company, receive a background check, and undergo onboarding. Next slide. Some exciting updates regarding COVID-wise. As of Wednesday, January 26th, we estimate that about 23% of Virginians aged 18 to 65 with a smartphone have downloaded the app. Yesterday, VDH launched a new COVID-wise verification code portal. This portal allows users with a positive viral COVID-19 test to self-obtain a verification code to anonymously report their test results in the app. The portal link is available on the COVID-wise landing page under the Did You Test Positive for COVID-19 box and on the If You Are Sick page. Individuals can access their test result verification for 7 days after their test date. The app also had some additional updates, including the ability to select a symptom onset date, virtual VDH agent, improved exposure notification screen with icons, a full integration with the national key server. There are currently 20 states using the national key server, including Maryland, DC, and North Carolina. So exposure notifications can be seamlessly shared across state borders and various applications. Next slide. On Thursday, Virginia began sending text messages to people who receive a positive COVID-19 viral test result in Virginia. These texts will come from 804-336-3915 and will only be sent between the hours of 8 a.m. and 8 p.m. These texts will provide rapid notification and encourage anyone who has a positive test for COVID-19 to stay home and away from other people. The messaging, which is also available in Spanish, will then provide a link to the new COVID-wise verification code portal. Again, this online portal allows individuals who have tested positive for COVID-19 to obtain a self-verification code, which will let them anonymously submit their test results through COVID-wise. Next slide. So finally, moving on to updates from our informatics and information systems team. The VEDS production system will be upgraded this Saturday, the 30th, between 1 and 7 p.m. Because the upgrade impacts how messages are consumed, the import process will likely be stopped on Friday evening to ensure all have been ingested prior to the upgrade. Due to the importers being off, the case counts reported on Sunday will be lower. Enhancements this cycle include, but are not limited to, the ability to manually add COVID-19 vaccination events. COVID-wise PINs fields will be hidden. The DRR will no longer show ask on order entry questions. For example, it will no longer show clinical questions asked on order entry. Plus, events like lab reports will be sortable in the patient file, and overall, we'll see improved queue performance and compilation of reports. Next slide. So regarding Sarah Alert, the next upgrade is scheduled for Tuesday, February 9th. Some desired enhancements were bumped from this week's release to the next one, including the close contact in the advanced filter. The team in other states have been discussing with the Sarah Alert developers on adding a vaccination field. Just a few reminders: district point of contact should be emailed when they are recipients of a contact or case transfer. This is important to ensure monitorees do not fall through the cracks. And lastly, when a contact lives out of state, remember to update their state address and close the record as not monitoring to ensure the state-to-state transfer process goes smoothly. As a reminder, the transfer process happens outside of the application. That's all I've got today, James. Happy to take any questions in the chat. Thanks.
Thank you, Carrie. That concludes today's session. If you've joined the meeting by WebEx, please type any questions for presenters in the chat box. If you've joined them by phone, please email your questions to donald.moore@vdh.virginia.gov with the subject line LHD call question. I'll leave the session open for the next few minutes or so to see if any additional chat questions come in. If I start seeing that there's no questions coming in, I'll go ahead and end the meeting at that time. Otherwise, have a great weekend and enjoy the day. Thank you, everybody.